So our next presentation is with Dr. Andrew Hendifar, who you've already met, a medical oncologist, and the leader of the Neuroendocrine tumor program at Cedars Sinai. He's going to talk about the latest in NET medical therapies. And another fun fact about him, during the summers in college, he didn't just play around. He worked at the NIH lab, and so he was working hard.
A few of us have been to Bethesda. Thank you very much. All right, this is good. Okay, I'm glad I put these slides in because we really didn't cover it today. But it's interesting how this field has progressed over the past few decades and how we came up with this term carcinoid. It's actually from the German word Carcinoid. My German accent's really bad. And by Sigrid Obendorfer, who's a German pathologist from Munich. And what it means, it's kind of like cancer, which I think is a very accurate term in a weird way. I think, is this laser pointer good? Let me see. Yeah, so I think the most important part of today, not the most important, but the most important part of my talk is probably the words that we use and what they mean. So we say neuroendocrine tumors or NETs. These tend to be the low or intermediate grade. They're the well-differentiated tumors. And then we say neuroendocrine carcinoma, we mean poorly differentiated. And actually, I have a better slide to show that. But I'll do it later. The other part that's important, yeah, that kind of day. The other part that's really important is, we call them all neuroendocrine tumors, but they come from all different parts of the body, right? So how often is that? You have a breast cancer group, and it's just breast cancer. You have a prostate cancer group and a colon cancer. And then we have the neuroendocrine tumor group, and we're talking about everywhere, right? So it gets kind of confusing. But we kind of tend to lump them up into the foregut, which we put together the lungs. You can have thymus, stomach, pancreas. And then there's the midgut, where we have the ileum, jejunum, and the colon. And then we have the hindgut. And then within pancreatic NETs, we have a lot of omas. We don't have to get into too much detail with that. So again, when we say neuroendocrine tumor, we mean well-differentiated, we mean grade 1, 2. They can often be functional. There are a lot of times you find them by accident, so we call them incidental, and actually it's okay. We don't really necessarily have to do much. And a lot of the treatments we're talking about today are for those types of tumors. On the other hand, we have carcinomas, which are characterized as being poorly differentiated. They're sometimes called grade 3. This is probably not accurate, sometimes functional, but almost never functional, meaning they don't really secrete any hormones that will affect you in a different way. And some of those other things aren't true anymore. The chemotherapy is now supplemented by immune therapy. So for poorly differentiated tumors or carcinomas, we can treat them with immunotherapy, which has actually changed the outcomes for lots of patients. And when we say these things, they're correlated with the way things look on slides. So I have to keep things simple. I'm a simple-minded person. So I have top 5 updates for 2024, okay? Drum roll. Number 1, yeah, thank you. Cabozantinib. The best study name is the Cabinet trial. So cabozantinib was approved this year for neuroendocrine tumors. These are graphs. I'm going to teach you 3 different graphs today. This is called a Kaplan-Meier. But basically, all you need to know is that this line is cabozantinib, this is placebo, and this one's farther along, so it's better. And the more separation, the better. So cabozantinib is better than placebo. Now, kudos to all the NET patients for enrolling in placebo trials. They're actually difficult. It's difficult to, participate in a clinical trial and possibly get a placebo. One of the ways to mitigate that, though, is that you can cross over. But thank you to the NET patients for getting this done. and then cabozantinib, there's more data. So there's two groups of patients. One was the extrapancreatic, which could include all types of NETs from all the different parts of the body I talked about. And then here's the pancreatic NETs. And it worked great in both types. This is my favorite slide. It's the pill bottles. So this is the actual dose from the FDA on the label, but this is the dose. These are the doses that sometimes you'll get instead. So if 60 or 40 or 20, depending on how you tolerate it, you're going to get a different dose. Not everyone can tolerate the same amount. All right. Number 2, belzutifan and Sutent for PPs, pheochromocytoma and paraganglioma. Now, these are rare. Yes, she got excited. Yeah, these are really rare subtypes, but the more medications we get for these types of tumors, the more we learn about them, the more we understand them, and they become not as rare as we thought they were. In this study, sunitinib, so sunitinib is called Sutent also, and this medication is frequently used for pancreatic neuroendocrine tumors. And here, they studied it in pheochromocytomas and paragangliomas, which is a rare type of neuroendocrine tumor. And so here's a second statistics lesson for today. Anyone knows what kind of plot this is? This is a waterfall, right? It looks like a waterfall. You see it? Except this one is not going up the wrong way. But so this is the patients on the medicine, and these are the ones who got placebo. Now, why 3 patients did better on placebo? I don't know. But they did, but this is still much better, and this medication is now approved. Now, belzutifan is what's called a HIF-2 alpha inhibitor. What that means, I don't really know either. But the way it works is this is the brain of the tumor cell, and this is the outside of the tumor cell. And when you have cancer, the signaling, it doesn't quite work like it should. You'll have a cellular process that goes slowly typically, and a tumor cell goes like this really fast. So when we can target that cellular process, we can actually kill the cancer. And that's what belzutifan does in a very focused way for certain tumors. So first it was approved for a certain type of tumor that's associated with von Hippel-Lindau, and now it's being extended to other types of tumors, including pheos and paragangliomas with success. All right, number 3. It get harder to pronounce. Tarlatamab and other DLL3 targeting treatments for neuroendocrine carcinomas. So here we go. This is a nice graph I stole from the internet. This is a tumor cell here, and one of the ways we can attack tumors is we form antibodies. So tumors have little things sticking out. In this case, it's DLL3, which is a protein, and then we can create an antibody. But sometimes the antibody isn't enough to kill it, because it really depends on the interaction between this protein and the cell. But what they designed are these, what we call them BiTEs. It's an acronym for bispecific T-cell engager. Okay, what does that mean? So one part of the drug binds to DLL3, one part of the drug binds to the T cell, and that's when the magic happens, and everything dies. So what we have to do is we look at the tumor cells on a path slide, and we stain it for DLL3. And many of you have been through this process. And this is exciting because tarlatamab was approved for small cell carcinoma, small cell lung carcinoma, which is in the family of neuroendocrine cancers. So now it's being studied in all types of neuroendocrine cancers, and many of our patients are getting benefit from these treatments. And here you see, this is a swimmer's plot. Mary, are you here? This is the show-off Mary at the top. She's the fastest in the swimmer lane all the way here. And then the swimmer plot, this is me in the bottom. I'm going to get there soon. But as you can see, this means the farther out you go, the better you've done. And here's 2 doses. So this is a swimmer's plot. So we got waterfall plot, swimmer's plot, Kaplan-Meier curve. You remember those, you get A. All right, so yeah, tarlatamab is really good, it's approved. But even more important for our community is that there's lots of new medications that are being developed and being studied. And they're modifications of the theme. So here we have a tri-TAC, a tri-specific. It's not that important, but meaning it's a new field. Once a medication's approved, iterations of it are developed, and that's great for our patients. All right, number 4, the NETTER-2 trial. We've talked about that already today. Anyone remember what kind of curve or graph? No one's. Oh, shoot. I'm such a bad teacher. Okay. Here you see the 2 different lines. There's a big difference between the 2, right? That's very good. And in this trial, unlike NETTER-1, we looked at using Lutathera in patients with grade 2 and grade 3 NETs, and using it right away instead of waiting for them to fail another treatment. And it looked really successful. The results were probably better than expected. And so now it's actually a possibility that maybe, and there's a lot of, we didn't hear about this today, but in Europe and the US, there's a lot of differences on how neuroendocrine tumors are treated. So with time and with more research, those differences will kind of go away. Because there's just different, I would say, histories between the 2 continents as far as how we treat these tumors and the philosophies. And a lot of it has to do with which doctors treat the patients. But with time, it'll become more globally aligned. And NETTER-2, I think, is going to help that. So what does that mean? So Lutathera is a great treatment for neuroendocrine tumors. It's approved for a lot of them. It's not approved yet for these in the red. These like lung, thymus. I think Heidi's published literature on these types of tumors in PRT. So we have good data, and it's being used more and more. So really, Lutathera, even though it started on midgut NETs, is now being used in a lot of different tumors, which is very important. Now finally, what I think is really important and not really a medical treatment, sorry to the sponsors, is carcinoid heart disease. And we heard a really touching story about that. But it's an important issue. So when you have a midgut tumor, it can probably make serotonin pretty often. How often? It depends what paper you read. But in my experience, maybe up to a quarter of patients with midgut tumors, their tumors will make serotonin. That will lead to flushing and diarrhea. So flushing and diarrhea is livable. It's annoying. It's an inconvenience. But the one thing that we have to look out for is these patients who have the serotonin in their blood, they might get damage to their heart valves. Okay? And when you damage the heart valves, the issue with it is that it's hard to diagnose. You don't want to diagnose it when you have leg swelling and other things. You can, but it's better to get it earlier if you can, because the surgeries are easier. But even more importantly, there's new technology. And what is this new technology? Is that they can replace heart valves now through your groin. So there was a time in my career where open heart surgery is not easy. We can probably give a whole day seminar on how it's not easy, right? Yeah, I can't imagine. It's not easy, but it's necessary. But now, and this is recent, this year, there are valves that have been approved by the FDA that you could go through the groin. So instead of doing open heart surgery, they literally put a device through your groin, they snake it up your blood vessel, they go to your heart, like you see here, and through a tube, they deploy a new valve into your heart. So you can replace the valves in your heart with the small little groin. It's almost like an IV, and that's it. Can you imagine? How big of it? Yeah. He's like, I came a year too early. Yeah, it's changed this past year. And yeah. There's all different types. Yeah, there's all different types. You'll be shocked how many different valves, because each company makes valves and each valve, there's the tricuspid valve, there's the pulmonic valve, and on the other side, there's the mitral and aortic. And each one has their own device, and then each company, so you know what I mean? There's like 5 or 6 companies that makes them, so there's probably like 30 different valves that you can use. A lot of times they'll do imaging of the heart and configuration to try to figure out which valve is right when they do it through the groin. Okay? And I think that ends it for today. Thank you for your attention.